Carpal tunnel syndrome is one of the most common disorders that patients come to me for. Carpal tunnel is almost like a vice-like pressure on the nerve called the median nerve at the wrist. The nerve gives sensation to the thumb, index finger, long finger, and half the ring finger. Most patients complain of numbness and tingling, oftentimes dropping objects, and sometimes with pain. Classic symptoms of carpal tunnel include nighttime symptoms. Patients will oftentimes awaken from their sleep and shake their hand to restore sensibility. Other activities, sometimes known as fixed wrist activities, will bring on symptoms of carpal tunnel. This includes driving a car, talking on a telephone, or holding a book. Fortunately, most cases of carpal tunnel can be treated conservatively. Splints are one of the first things that we try. One of the common misconceptions is that a splint should bend the wrist back. Splints made for sprains do that. On the other hand, for carpal tunnel syndrome, the splint should be straight. This helps minimize the pressure on the nerve. The second treatment is an injection of cortisone. Studies have shown that up to 40% of people can be treated and cured permanently with an injection. There are some misconceptions about cortisone. First, cortisone doesn't provide immediate improvement. Pharmacologically, it could take 1 to 2 weeks before the cortisone starts to work. Second, people oftentimes think that cortisone is used to mask symptoms. It's not. In 40 to 50% of cases, we can help cure carpal tunnel through a combination of the injections and splints. With people working on computers and keyboards more often, repetitive motions are a risk factor for carpal tunnel disease. Ergonomics and body positioning is something critical to talk about. I've seen many patients whose chair height, keyboard height, computer monitor are in inappropriate positions, and if the workstation is not ergonomically correct, this can lead to symptoms of numbness and tingling. Simple corrections in someone's workstation could also help eliminate symptoms of carpal tunnel. Most patients can improve through these non-operative measures. On the other hand, when symptoms continue, oftentimes I will send my patients for what's called a nerve conduction study. This is a study performed by an electrodiagnostician who will document and demonstrate how severe the carpal tunnel is and help rule out other neurologic problems. Some practitioners use in-office testing. The in-office tests are only a screen test. They should not be considered diagnostic. When the studies are positive and patients don't respond to non-operative treatments, surgery helps 90 to 95% of people with carpal tunnel. Surgery is done as an outpatient basis. I do it under local anesthetic. The anesthesiologist is there to monitor you. You can be wide awake or a little sleepy. The surgery generally takes about 10 minutes, and patients go home the same day of surgery. I strongly believe in getting you back to your activities as soon as possible. 2 days after surgery, you'll come in and see the therapist. They'll change the dressing and actually start you in range of motion exercises. I encourage people to get back to their normal activities as soon as they can. Fortunately, most patients with carpal tunnel can improve through conservative treatment. When that doesn't work, surgery has a very, very high success rate. I look forward to seeing you and talk to you about your carpal tunnel syndrome.